Well, just to start out with, prostate cancer is the most common form of malignancy in men. And if you look at the statistics by Siegel and all for 2023 in the US, it will account for 29% of all male cancers. And they're projecting like 288,000, over 288,000 new cases and 34,700 deaths in the US alone. Across the world, prostate cancer is the fifth most common form of cancer in men. Now, when you look at non-metastatic castration-resistant prostate cancer, this, when I looked in the past, was accounting for some 50 to 60,000 men per year. Like that's enough to fill a football stadium of people. But until now, it's been defined by CT scans and bone scans. So we don't really have trials yet utilizing PSMA scan, which in the United States has just recently been approved. So that must be kept in mind. So there are three really important trials in non-metastatic castration-resistant prostate cancer. One is the PROSPER trial with enzalutamide, and one is the SPARTAN trial with apalutamide, and the other is the ARAMIS trial with darolutamide. I was the principal investigator of the PROSPER trial that had over 1,400 male patients, and they were non-metastatic CRPC, reviewed centrally. The radiologist looked at the bone scans and the CT scans, again, conventional scanning, and patients had to have a rising PSA despite castrate testosterone level, which means usually less than 50 nanograms per deciliter. With a baseline PSA of over 2 nanograms per ml, and PSA doubling time, this is important, of less than 10 months. Now, all three trials relied, it's very important to understand this, on conventional scans, randomizing men 2-to-1 to either ADT and active therapy with one of those three drugs I mentioned, or ADT and placebo. And I think the first thing that we learned from the PROSPER trial is that treatment of these high-risk men, again, the doubling time of less than 10 months with enzalutamide, the risk of radiographic progression or death decreased by 71%. And the median metastasis-free survival was improved by just under 2 years as compared to placebo and ADT, leading to a delay in the onset of symptomatic metastatic CRPC and allowing, I say, patients to remain active for longer. The time to chemotherapy was markedly longer. And even more importantly, this delay in metastases resulted in a significant 27% lower risk of death when compared with placebo. The median improvement in overall survival was almost 1 year as compared to placebo. So enzalutamide and ADT was approved in many countries on the basis of these data. And also quality of life was maintained. Clinically meaningful patient-reported outcomes such as pain progression, urinary symptom worsening, and bowel symptom worsening were significantly longer for the enzalutamide versus placebo group. Now, all three of the studies, the ARAMIS study, the SPARTAN, and the PROSPER study, all had very similar results and designs, and they have become the standard of care and led to approval for these three drugs. I think that by all those trials, we likely were treating micrometastatic disease early. And we know we developed drugs very often in late stage, and then the earlier we put them, the more effective they are. So then when you treat heavily pretreated patients, it's very hard to get a signal. But if you put drugs earlier and earlier, they usually work better. So it's very likely that we were treating micrometastatic disease that wasn't picked up on conventional CT scans and bone scans. And with as PSMA scans are more widely available, I think this population will be probably recategorized as metastatic hormone-sensitive prostate cancer. But just realize that the PSMA scans were approved in the United States just last summer, so we don't have them so widely available. That's been the problem.